Today we will have a class on basically on the diseases of stomach. Okay, so first I will start with peptic ulcer disease. Okay, so the most common type in peptic ulcer disease we include both gastric ulcer as well as duodenal ulcers. Okay, but the most common type of ulcers are usually duodenal ulcers. Whatever it is, means in the stomach or within the duodenum, and in the duodenum it is most common within the first part of the duodenum. You need to know this because in the stomach and the duodenum they present most commonly with complications of either hematemesis, I mean to say whether they will present with the complication of bleeding, or in surgery they present with the complication of perforation. Okay, so we need to know and differentiate the duodenal ulcers from gastric ulcers. Okay, so starting with the gastric ulcers, there are usually 5 types of gastric ulcers. They are classified based on the Johnson's classification. Okay, so in type 1 ulcers, the ulcers are basically along the lesser curvature of the stomach. Okay, in type 2 they are in the prepyloric region and in the duodenum. In type 3 they are only in the prepyloric region. Type 4 they are along the lesser curvature but higher up along the body, and type 5 is diffuse ulcers. Now the ulcers here are mostly associated with either increased secretion of HCl or because of decreased defense system of the stomach. So in type 2 and type 3 ulcers usually we have increased acid secretion, and rest of the ulcers usually we have decreased defense system of the stomach. So we find the ulcers most commonly along the prepyloric region as well as in the duodenum in type 2 and type 3 type ulcer. Okay, so the patient may present to you with different type of complications. Okay, so first presentation, the patient might give you just simple heartburn, or say the patient may present to you with features of dyspepsia. Also there may be presence of pain in some cases, and in surgical cases we usually encounter the patients with perforation, either with gastric perforation or with duodenal perforation. So what do we do when we find a patient with perforation? So the first common thing, the patient will present with diffuse peritonitis. So whenever you touch the abdomen of that patient, the patient will clinch in pain. Okay, so what is the most definitive diagnostic investigation we can do in case of if we suspect perforation? The first thing is we can go for a chest x-ray. Mind it, it's not abdominal x-ray, it's chest x-ray, because we want to see the free gas under the right dome of diaphragm. See, usually whenever we take x-ray of a normal individual, we might see free gas under the left dome of diaphragm, but that's actually not free gas, that's gas present in the fundus of the stomach. That may be confused with free gas in the abdominal cavity, but that's usually a fundal gas shadow. But on the right side, any gas shadow under the diaphragm is usually abnormal, except a single case where we find Chilaiditi syndrome. It's the interposition of the colon between the liver and the right dome of diaphragm. Okay, so other cases also we might get free gas under the diaphragm. For example, we might get, if we just take x-ray of a post-operative patient, maybe open case or a open laparoscopic case. Also, if there is a subphrenic abscess involving the gas producing organisms, then we might find free gas under the right dome of diaphragm. But we need to differentiate because we need the treatment protocols are entirely different. Okay, so basically whenever a patient comes to the emergency with perforation, after we diagnose it with a x-ray, we do not need to do any other investigations, and we should not wait. We can proceed with emergency operation. What do we do in a case of peptic ulcer or gastric ulcer or duodenal ulcer perforation? We usually go for a Gram's patch repair. Okay, So what are the other procedures we need to do along with that Grams patch repair? If it is a big ulcer and if it is associated with any underlying mass, so we should suspect that there may be underlying malignancy. So we should always take biopsy from the margins of the ulcer. Okay, and if you do not find a mass, then you can just take simple biopsy and close it up with Grams patch repair. What do? We put a patch of omentum and just close the perforation. But if it is a case of duodenal ulcer, the chances of malignancy is very less, so usually we do not need to take any biopsy. Now if we suspect a perforation and do not find any free perforation in the abdomen, what should we do? So it may be a perforation in the posterior wall of stomach, so we should always explore the posterior wall to look for any perforation in the posterior wall of stomach. Okay, so after that, earlier what we used to do acid reduction surgeries along with the perforation repair, but nowadays we do not do because of the advent of modern PPIs, which are very good for reducing the acid production capacity of the stomach. Okay, but still you should know what were the operations we can still do for reducing the acid. Those are vagotomy, truncal vagotomy, selective vagotomy and highly selective vagotomy. In highly selective, usually we do highly selective vagotomy. In those operations, we usually spare the branches to the gallbladder and the region of the pylorus, because if we cut the branches of vagus to the gallbladder as well as to the pylorus, what will happen? It will cause stasis, and if there is stasis in the gallbladder, there will be stone formation, and if there is denervation of the pyloric region, it will not cause spontaneous emptying of the stomach and will need a drainage procedure along with the operation. So what else is needed for the treatment? Okay, once after the perforation is repaired and the patient starts taking orally, we must include anti-Helicobacter pylori treatment, because Helicobacter pylori is the most common organism that is found in peptic ulcer disease. So what are the usual tests we do? We can do the urease test, and usually we give 14 days of PPI treatment along with 2 antibiotics. That is, either we can go for triple therapy, and earlier quadruplet therapy was also given, but now usually we give triple therapy, antibiotics as well as high dose of PPI. Okay, now what were the other operations that were done for acid reduction surgeries? Okay, we used to do Billroth 1, Billroth 2, that you need to know because it's of historical importance. Nowadays, usually we do not do Billroth 1 and Billroth 2. We usually, if any bypass procedure is required, we usually do Roux-en-Y gastrojejunostomy. Okay. Now, as I have told about the vagotomies are usually of historical importance, but usually if there is recurrent ulcers, then we need to do vagotomy. So usually the least recurrence is with truncal vagotomy, because it denervates the entire stomach and there is no acid production. On the other hand, if we do a selective vagotomy, there is chances of recurrence, but the problem of gallbladder stone as well as stasis to the stomach is very less. Okay, now after repair of a perforation, what are the things we should advise to the patient? The patient should not, once the perforation is repaired, the patient should avoid the risk factors which predispose to the perforation and causation of ulcer, that is smoking, very high protein diet, alcohol, and smoked foods. Specifically, smoked foods predispose to increased incidence of gastric ulcer, and this is also important because this might predispose the patient to gastric cancer. Now coming to gastric cancer, what are the usual risk factors for stomach cancer? First, it is smoking. What does it do? It reduces the mucosal barrier and predisposes the injury to acids in the stomach as well as in the duodenum. Second, alcohol consumption, it also increased acid production and causes damage to the stomach as well as duodenum. Consumption of smoked food and fishes. So usually gastric ulcers and esophageal ulcers are most common in Japanese people because they consume more of smoked food and preservative rich foods. Okay, so H. pylori is again very important in causation of gastric ulcer. Now, what are the other less important causes? Those are post gastrectomy and reconstruction procedures, Menetrier's disease. Okay, again we have adenomatous polyps, gastritis, type A blood group. These are the some risk factors which lead to causation of stomach cancer. Okay, so what is the most common site of stomach cancer? So in the Western world, it is basically the proximal stomach, and the reason behind this is increased incidence of gastroesophageal reflux disease. Okay, so more of fatty food and carbohydrate rich food causes increased reflux, which causes acid injury to the lower esophageal junction as well as the upper part of the stomach. So in proximal stomach, usually these cancers occur in Western countries. Along with that, it also predisposes to esophageal cancers. Okay, but in Asia and overall the world, the most common site is antral region for gastric carcinoma. Okay, it might occur in the body of the stomach also, but these two are the commonest site. Now we have different classifications for CS stomach. Okay, so one classification is microscopic classification and the other is the Lawrence classifications. In Lawrence classification, it is basically diffuse type or intestinal type. Okay, so in diffuse type, what are the things we find? It is mainly because of familial factors. Women are more commonly affected than men. As it is a familial cancer, it occurs more commonly in younger age group. It is poorly differentiated and has a signet ring cell appearance. Okay, and intestinal type is most commonly because of increased environmental factors. It is more common in men than in women. Okay, there is increased incidence with age and there is increased microsatellite instability. Okay, now we have the early gastric cancer. You should know this because in early gastric cancer, it is usually treatable by endoscopic procedure if the tumor lies above the submucosa. Okay, so this early gastric cancer was the classification was given by the Japanese classification because this lies above the muscle layer and it can be removed by endoscopic mucosal resection or endoscopic submucosal dissection. Okay, now the diffuse advanced gastric cancer, this can be classified by Borman's classifications. So we have 4 types. You should know type 1, type 2, type 3 and type 4. Among this, the type 1 has best prognosis because it is a polypoidal type of growth from the stomach bed. On the other hand, the type 4 is diffusely infiltrative type and it has the worst prognosis because it diffuses into the entire stomach and has lymph node metastasis very early. Okay, so it is also type 4 is also known as Linitus plastica. Now, what are the presentation? Okay, clinical features. So earlier it was told that gastric outlet obstruction was most commonly because of it most commonly occurred because of a sequelae of gastric peptic ulcer disease. But now it has been seen that the most common cause of gastric outlet obstruction is stomach cancer. So what are the presentation of stomach cancer? So the first thing you should note is it presents with the features of weight loss, that is unexplained weight loss. Number 2, there may be a lump presentation in the abdomen. if the disease has advanced, the patient may present with gastric outlet obstruction, and there may be new onset dyspepsia. But new onset is important because a patient who did not have any symptom of dyspepsia suddenly started having dyspepsia. This is important to rule out other causes of gastric outlet obstruction. We might have dyspepsia from prior also, because some cancers might occur in gastric ulcers also, but new onset dyspepsia is usually defined for stomach CA. Okay. Now there may be some atypical presentations of gastric cancers. Okay, what this might be? There may be a sister Mary Joseph nodule. What is it? It is periumbilical metastasis, which is most commonly seen in gastric cancer, but it can occur in other cancers also, like ovarian cancer or others also, but the most common cause is gastric CA. Okay, then it might present with Krukenberg tumors. What is Krukenberg tumors? It is bilateral ovarian metastasis. So most common cancer which give rise to Krukenberg tumor is gastric CA, but it can also occur in colorectal cancers as well as in breast cancers. Okay, so earlier it was thought that Krukenberg tumors usually occur by transcelomic spread. That means drop metastasis from the gastric CA down to the ovaries. It was thought that this way was the spread of gastric CA to ovaries, but it has been seen that there is retrograde lymphatic spread to the ovaries from the stomach for causing Krukenberg tumors. Okay, so what are the other presentation? There may be a left axillary lymphadenopathy. It is also known as a Irish nodule. It most commonly occurs in gastric CA. Okay, there may be Volcho's lymphadenopathy. You might be knowing this. It's a left supraclavicular lymph node. Okay, it's not that it can occur only in gastric CA, because some other cancers also, like any other urological cancer, colorectal CA, any abdominal cancers might disseminate to the left supraclavicular lymph node, causing the Volcho's lymph node. This is a poor prognostic sign because it is a sign of advanced disease. Okay, then the patient may have Bloomer's shelf. Now what's a Bloomer's shelf? It is pelvic metastasis into the pouch of Douglas. So there are rectovesical deposits which can be felt on parorectal examination. Okay, so we might feel hard deposits while doing a parorectal examination. So this is Bloomer's shells. This is not only present in gastric CA, but any other intra-abdominal cancer can present with Bloomer's shells. Okay, then we have migratory thrombophlebitis. Okay, this is known as Trozius syndrome. The most common cause of Trozius syndrome is pancreatic CA, but it can be found in stomach CA also. Now, other less important facts are trippy palms, because these are hyperkeratotic palms, as well as there is Lazar-Trillette sign. What's Lazar-Trillette sign? It's multiple seborrheic keratosis that can occur in any internal cancer, but it usually gets cured when the primary source has been removed. Okay, now how do we diagnose a case of gastric CA? The first and the foremost investigation when you suspect a patient with gastric CA is upper GI endoscopy and biopsy. Okay, so it helps in not only seeing the mass, because while doing an endoscopy, if there is a fungating mass in the stomach, we can directly visualize the mass with the endoscope, as well as we can take biopsy for tissue diagnosis. Okay, so the tissue diagnosis will be telling us what type of cancer it is, because the most common type of cancer is adenocarcinoma, and we can know the type, as well as we can know the extent of the disease. What is the size of the growth, how much of the stomach is involved, we can know by upper GI endoscopy, and biopsy will confirm this whether it is carcinoma or not. Okay, so after doing upper GI endoscopy, if we see that there is a mass in the stomach, next what investigation we should do? We can go for CCT of the whole abdomen on the thorax, or we can go for a PET CT for staging purpose of the disease. Because if it's a early disease, we can go for just endoscopic mucosal resection or endoscopic mucosal dissection, and if it is a advanced disease, we might need to do distal gastrectomy, subtotal gastrectomy, or total gastrectomy, depending upon the site of the carcinoma, okay, and the features. And if there is advanced disease, that it is a metastatic disease, then we can simply go for bypass procedure, that is gastrojejunostomy, and other stenting procedures are also done nowadays. Okay, so what one more investigation is usually done in case of early gastric cancer, that is endoscopic ultrasound. Endoscopic ultrasound, why it is important? Because it helps us to know accurately the T staging and N staging of the disease. T is the local staging as well as the nodal status of the disease by doing the endoscopic ultrasound examination. I won't go into the TNM staging. Now I'll come to the how can we manage a case of stomach CA. Okay, so first, if it is a locally resectable disease, whatever it is, we'll do first the surgery to remove the mass. Okay, but if it is a metastatic disease and it has spread into the entire abdomen, then we can simply go for a bypass procedure and just treat the symptoms in a palliative manner. But if it is a resectable case, then what we can do? We can do a resection of the tumor, including a 5 centimeter proximal margin, and the distal margin will be usually till the pylorus. Okay, so whatever is the extent, for example, if the carcinoma is in the lower half of the stomach, it's near the antrum, then what we can do? We can simply go for a distal gastrectomy. But if the carcinoma is in the middle third of the stomach, we need to do a total or subtotal gastrectomy. And if it involves the upper third of the stomach or the gastroesophageal junction, then we might require a total gastrectomy and reconstruction procedures. What are the reconstruction procedures? If we do in the lower third, we usually do a gastrojejunostomy. The gastrojejunostomy procedure, again, it can be either anticolic or retrocolic. That is, either we do it in front of the colon, or we just make a rent in the mesocolon and do put the gastrojejunostomy from the posterior part of the mesocolon. Okay, so what are the lymph node stations that has to be removed after along with doing a gastrectomy? Okay, so we usually do a D1 gastrectomy or D2 gastrectomy. So what are the lymph nodes usually we remove while doing a D1 or D2 gastrectomy? So in D1 gastrectomy, usually we remove 6 lymph node stations, and while doing D2 gastrectomy, we remove additional lymph node stations till lymph node station 11. Okay, so what are the various lymph node stations? So 1 to 6 are along the stomach. So 1 is right paracardiac, 2 is left paracardiac, 3 is the nodes along the lesser curvature, 4 along the greater curvature, 5 suprapyloric, and 6 is infrapyloric. So when we remove the 1 to 6 station of lymph nodes, it is known as D1 gastrectomy, and when we remove the others till lymph node station 11, it is known as D2 gastrectomy. So what are the additional nodes we remove? While removing the 7, it is the left gastric, the nodes along the left gastric vessels. Number 8 are those along the common hepatic vessels. Number 9 are those along the celiac axis. Number 10 are those along the hilum of the spleen. 11 is again divided into 11 proximal and 11 distal. Those are along the splenic artery in the posterior aspect of the pancreas. Okay, so if we remove the lymph node station 1 to 11, then it is known as D2 gastrectomy. So if you have any questions, just please ask. Please turn off your videos. Yeah. Do you have any questions till now? Just any doubt or anything? No. Okay. You got some idea at least what I told? The other people, please come online. Yes, please. Your question?
Uh,
Any question?
yes, sir. Sir, if there is any perforation and a mass
Okay.
together,
Yeah.
should we go directly for the biopsy or repair the perforation first?
See, if there is a mass along with a perforation, okay. So if there is a mass and a perforation, we should always suspect of malignancy. So first thing we should do, we should take biopsy from the margin of the perforation. Okay. After that, we repair the perforation. Okay, we have to do the both thing. We
Okay.
will have to take the biopsy as well as we'll have to repair the perforation. And if it comes
Okay,
out
sir.
to be malignancy, then we treat it later according to the staging of the disease. Okay.
Okay. Yes, sir.
Anyone else? Anything? I can see Abhijit, Jubair. Anything you want to ask?
No, sir.
Okay. Okay, then I'll give you a brief idea about gastrointestinal stromal tumors now. Okay. So usually where does this tumors arise? These are usually both means they have a benign course of presentation, but means if there is prolonged symptoms, they might turn out to be malignant also. They usually arise from the intestinal pacemaker cells. Okay, so most common site of GIST is usually the stomach. Okay, so it may have a sporadic presentation as well as it might have a familial presentation. Okay, so whenever they have a sporadic presentation, okay, we have usually other diseases associated with GIST. Okay, so when the presentation of GIST is in a sporadic case, we usually have a Carney's stride. Okay, so now what's a Carney's stride? Usually we have a gastric GIST. Along with the gastric GIST, we have paragangliomas as well as we have pulmonary chondromas. Okay, so in which is more common type, usually we find that the sporadic cases are more common than the familial cases. Okay, but usually in other diseases, whenever there are familial cancers, usually the other associated cancers are more common, but this is not so when we find a GIST, because the other tumors, like there are no pulmonary chondromas when a patient has familial GIST. The disease is usually more aggressive, but the other malignant diseases in associated with GISTs are not available in a familial cases. Okay, so why it is means the sporadic case, usually we have, what are the mutations? Usually we have the most specific mutation is the dog1 mutation. Okay, so gastric GISTs are usually multifocal and aggressive. Okay, they usually behave like sarcomas. Why they behave like sarcomas? Because usually they do not have any lymph node metastasis, because we need to differentiate gastric GISTs from gastric carcinomas, because the gastric GIST usually do not metastasize to the lymph nodes, so we do not need any lymph node dissection. As I have told you, the D1 and D2 resections are usually not required in a case of GIST, but usually we go for D1 D2 lymph node resection in cases of gastric cancers. Okay, so the treatment procedure is also a bit different. Okay, the clinical, first I'll come to the clinical presentation. Usually the clinical presentation are same, like they can present with either hemorrhage or they can present with dyspepsia, they can present with mass in the abdomen, but usually they can enlarge to a larger extent before producing the symptoms. Okay, the treatment protocol is a bit different from gastric CA. Okay, now the investigation of choice, usually we do not require a biopsy for diagnosis of a GIST. GIST is mainly a radiological diagnosis. Usually we can do a CCT whole abdomen to see the mass in the walls of the stomach. Okay, so management, basically, if it has not caused any ulcer, because when a mass grows too rapidly, it can cause necrosis of the overlying mucosa and ulcer might be there. But if there are no ulcers, we can simply directly go for resection of the tumor. Okay, usually in stomach Usually in carcinoma cases, we do resection 5 centimeter proximal and distal resection margin is till the pylorus. But this is not the case with GIST. We can simply go for en bloc resection of the tumor itself, and we do not need to do a total gastrectomy or partial gastrectomy for GIST. If it is a very small tumor, we can just go for 1 centimeter margin and removal of the tumor. Okay, and nowadays it is said that it is safer to do a 2 centimeter margin resection so that there is no local spread. Okay, but we do not need to do any lymph node dissection. Now, after doing the resection, what are the main drugs we usually give? These are usually imatinib. Okay, we give imatinib. If the patient is resistant to imatinib, we can give sunitinib or sorafenib. Okay, now it depends whether it is a benign GIST or a malignant GIST, because a malignant GIST has more aggressive behavior than the benign GIST. So some points about gastric lymphomas. Okay, so the gastric lymphomas, most commonly they are involved as a secondary procedure. So the lymphoma anywhere else can involve the stomach as the most common site of involvement, but there may be primary gastric lymphomas also. Okay, so usually they are B cell lymphomas and non-Hodgkin's large B cell lymphoma or diffuse large B cell lymphomas. Okay, and the stomach is the most common extranodal site in GIT to be involved with lymphomas. So if a patient has lymphomas, usually we do not need any resective procedures unless and until there is obstruction or perforation, which is not that common. We can usually go for chemotherapy that includes the RCHOP regimen. What is the RCHOP regimen? R is rituximab. We give C for cyclophosphamide, H for hydroxy, donorubicin, O for oncovorin, and P for prednisolone. Okay, we give usually the RCHOP regimen and follow up the patient. And if there is also recurrence, we can go for resection of the tumor. Okay. So, anything else you want to ask? Okay, just could you tell me what are the other topics that are left to be taught so that we can prepare it accordingly and bring the topics to you? Anyone? Yes, CR, please. Could you tell what are the topics left out so we can cover it up before your exams are due? Your class representative, please.
Yes, sir.
Yeah.
I have to see and I'll inform you later.
Okay, sure. You just see what are the cases on or what are the topics left. Okay, and let me know so that we can plan accordingly. Okay.
Okay, sir.
So
Okay,
any
sir.
questions you have?
No, sir.
Okay.